in terms of whether you're married or unmarried, you need to see your gynecologist, right? Because there's a lot of things that we can do as prevention, not just as treatment. And so you need to see someone that specializes in women's health so that you can continue to be healthy.
Hey, I'm Zainab.
And I'm Mia.
And welcome to another episode of Sprinkles and Spice.
And Ramadan Kareem.
Barak alaikum shak. To all the Muslim bestiyanas.
And the non-Muslim bestiyanas also.
Are we ready for Ramadan?
The month?
For the
whole month?
For the whole month.
Honestly, I'm ready for the first week.
For the first week?
Because the first week is the easiest. You're like, oh my God, I'm doing it. I'm fasting. I'm doing it. I wasn't going to do that. But like, 8th day, I'm like, I'm hungry.
Yeah.
I'm hungry.
I mean, we're filming this before Ramadan.
Yeah.
So
I'm not hungry right now.
We're not hungry right now. We're excited for it. But usually it's always like the first couple of days where it's tough. And then the rest of the month flies by. Don't you feel?
No, the first days, I'm like, this is so easy. I could fast every day. Me and Allah were connected. I'm telling you, 8th day, I'm like, I'm hungry. I have a tension headache. I need caffeine. I'm not okay.
Really? No, I feel like you get used to it after a while. And then what I like about Ramadan is that like we do stay up later. I mean, it does flip our schedule upside down, but it's nice because you get to sleep in. I mean, if you work, then you're not really sleeping in a lot.
Or if you are the daughter of my mother, you are not sleeping in at all. 8 a.m. Wake up. You gotta feel the fast.
She's like, you have to feel the fast. She's like, what is this fasting if you're sleeping in?
My mom is always like, people who sleep until 2 p.m., you're not fasting. I'm like, I want to sleep until 2 p.m. I don't want to feel this fast.
Look, she's not wrong.
No, but waking me up at 8 in the morning is a bit excessive. A bit excessive.
Yeah. Your mother said you will fast and you will feel it.
Mom, you're going to feel the fast.
Well, I think the theme for this month, we're going to be all about mental, physical, and spiritual wellness, health and wellness.
We love her.
We love her so much. But before we get into that, we have a little something in the studio.
We walked in the studio. We found the best surprise of our lives. This is when I peaked. Everything's downhill from here.
All right, hold on. Let's get this box.
We have a pro-life special edition spicy ketchup and regular ketchup chip box. It's a beautiful red translucent box. Can you do some ASMR with it? Can you tap it?
Box. Hey, we're about to open this.
We need to stop this ASMR. Nobody wants it.
Nobody wants it. So when I found out it was a ketchup flavor, I lost it. And then I found out it was limited. So I'm like, So they sent a tomato ketchup as well. They have their own tomato ketchup and it's apparently 15 calories per serving and no preservatives. I'm interested to taste this because you know me. One thing about me,
I like ketchup.
I love ketchup.
She likes ketchup with her eggs. She likes ketchup on its own.
Ketchup with eggs is not that scandalous.
No, it's not. To me, it's fun.
But a lot of people give me like the weirdest reaction, like ketchup on eggs. It's not that crazy.
It's common.
It's not that crazy, right?
Thank you. And I don't know about in Kuwait specifically, but in the UK,
I've had a lot of people. I mean, I think it's a very American thing. But I love mixing ketchup and hot sauce.
Okay,
do you do that?
The hot sauce that they brought has 0 calories.
What?
And I'm not gonna lie, I
will it pass the Mia test?
I'm kind of confused. I'm like, is it gonna be hot? Like, I kind of want to try it.
All right, let's try them. I wonder how long they're gonna be around because they are limited. So I'm trying the ketchup. Mia's trying the flaming ketchup.
Oh my god. Wait, I think this is my new favorite flavor.
Yeah, switch. Hold on. I want to try the flaming. Is it spicy?
No.
I'll be the judge of that. I like the ketchup more than the flaming ketchup because I don't get a lot of the ketchup in the flamin' ketchup. But this is bomb. This is so good.
The flamin' has like a almost like a flamed flavor to it.
Yeah. It does. Like a smoky flavor. It's really good. All right, let's get into today's episode.
Let's go.
While we munch on these.
I am so excited for today's guests. We have a doctor in the house.
An actual woman in STEM.
Finally. So we can stop lying about being women in STEM.
We're not lying. Who's lying?
Zainab, neither of us are doctors.
Sure. Anyway, I'm a doctor if I say I am.
We have a doctorate in delusion.
We are honored to have Dr. Alibrahim today as our guest.
Whoop.
She is an accomplished OBGYN with a degree from McGill University. She specializes in urogynecology and pelvic reconstructive surgery. Slay. She also specializes in robotic and minimally invasive gynecology surgery. These are all mouthfuls.
I was going to say, this is I want to say slay, but like, I'm like, what am I slaying?
I'm like, yeah, I don't understand what any of these are, but it's
Big
so
words.
impressive.
Big words.
And her expertise also extends beyond surgery, as she has also completed a clinical effectiveness program at Harvard, and she's very passionate about female well-being.
But Zainab, the most important part is that she is spam fam.
She is spam fam.
Which makes her extra qualified. That was a lot. Doc, is there anything else you specialize in?
So I also do perimenopause and menopause, so the health of a lady after the age of 40. And I also specialize in female sexual dysfunction. So if they have problems in terms of their sexual relationship, either in terms of physical pain or a decreased libido or a lack of ability to orgasm, then that's something that we treat medically.
There's nothing she can't do.
Yes.
Superwoman.
And an actual woman in STEM. We cannot stop saying.
We can't. We're so excited. We're like, women in STEM.
We always
I'm
joke
truly
about
excited
it.
to be here. Like
Thank
really,
you.
my sister and I kind of like look at your podcast in between our clinic or in between surgeries, like while we're waiting for things to happen. We're like, oh, let's see what they're talking about. So I'm really happy to be part of
See,
this.
doctor approved. In between surgery. We're going to put that sprinkles of spice in our bio.
Yeah.
Doctor approved.
In between surgeries is the biggest flex of my life. I feel so important and relevant. I feel like I have things to say. I have a message.
It is. It's fun. And I think a lot of the topics that you guys talk about really touch our hearts in terms of like people in society, right?
Yeah.
Because they're topics that are really relevant to us. And I just like how open you are about like talking about it. It becomes like real.
Yeah.
Instead of like a podcast which just kind of touches on ideas and vague. This is like detailed, it's real. Like I can feel like I relate to what you say. So thank you for that. Really.
Thank you, Zainab, for being the open one.
Well, today is also, I think, going to be an impactful episode as well that I think is much needed in the region.
Yeah.
We're going to be talking, obviously, about female wellness.
Yeah.
And health and wellness.
Health and wellness.
But I think specifically because we know that in the region, there is a huge problem when it comes to like PCOS and endometriosis. We're going to be focusing on these two since they're, I think, the most common. Correct me if I'm
It is one
wrong.
of the most common things that people complain about. So PCOS is polycystic ovarian syndrome.
Yes.
And بالكويت احنا نسميه تكيس مبايض. And endometriosis, which is بطانة الرحم المهاجرة. And it's quite common there, like in our societies as Arabs. So yeah.
I actually, when we were doing research yesterday, I found that I think it's 40 to 60% of women in the Gulf region, which is higher than the global average.
To be honest, I'm not sure about percentages in our communities because we don't do a lot of what we call population health.
Yeah.
So I'm not sure if the exact percentages are correct, but it would make sense to me because there is a genetic susceptibility to having polycystic ovarian syndrome or endometriosis. You'll kind of find it clustered within a family. So if you have it, your cousin might have it, your mom might have it, your aunt might have it. So yeah, that would actually make sense to me.
What about lifestyle? Does lifestyle also affect?
For sure. Like, I mean, relative to other communities, we kind of have a sedentary lifestyle and our machbous and our zbedi and our mtabbag, right? It makes a huge difference in terms of hormonal imbalance, right?
So for people who don't know, like from your point of view, what is PCOS? Like, is it something you're born with? Is it something you get later on in life?
So polycystic ovarian syndrome is basically, if I'm going to put it in a few words, it's a kind of imbalance of your hormones, right? And so a lot of people think that أنا راح يكون عندي تكيس مبايض if I do an ultrasound and they see lots and lots of little cysts or big cysts, right? And that's how people, but it's not actually, that's not how you diagnose it. It's a clinical diagnosis. It's a biochemical diagnosis. So basically, if someone has irregular menses, so their period doesn't come on time, or it takes quite more than 45 days between one period and the next, or it's truly short, like every 19 days, for example, that means that there is a little bit of menstrual irregularity, right? So that's one of the things that we diagnose polycystic ovarian. In addition, we have if someone has hyperandrogenism, which basically it's a big word that says that your male hormones are a little bit higher than average, right? And so then you tend to have acne, you have scalp hair loss. And also you have like excess hair all over your body in places where women shouldn't have that hair. So like upper lip, chest, things like that, right? So for example, a person might come and says that, you know, my menses is irregular and I do laser for hair removal, but I have to keep doing it, right? Usually there's a couple of sessions or like 6 sessions that you do for laser hair removal, and then that's it, right? But it just keeps coming. Right? So that's one of the ways that we diagnose polycystic ovarian.
Yeah.
Sometimes you do supplement with what you see on ultrasound, but you can't just diagnose with an ultrasound.
I think over the past few years, there's been a lot of awareness regarding the symptoms of PCOS. Because when I was diagnosed at 14, 15, around that time.
3 years ago.
Yeah, 3 years ago, actually. And during that time, the only thing that they prescribed to me was birth control, and nothing else was told to me. But I realized throughout the past, I think, decade, that it's directly linked to insulin resistance, which I think has been very like a hot topic recently. We always hear insulin resistance. So it's sort of like, who came first, the chicken or the egg? Is insulin resistance the culprit in PCOS, or is PCOS, does it cause insulin resistance?
So it's actually, so you have a genetic susceptibility to PCOS, right? And also your lifestyle makes a huge difference in terms of how the polycystic ovarian syndrome or PCOS kind of manifests, right? So it's kind of both of those together. And then once you have PCOS, once you have that hormonal imbalance, it affects you in many ways. So that includes insulin resistance. People are more predisposed to being a little bit obese. People are more predisposed to having cardiovascular conditions, right? And so it's the diagnosis of polycystic that kind of stems all of that, including insulin resistance. And so like when you do come to diagnose or treat patients with polycystic ovarian syndrome, you kind of want to think of all of that, right? So it's not just about, giving the OCPs or what we call oral contraceptive pills. Most people in the community know OCPs as something that prevents pregnancy, but no, it kind of harmonizes our hormones, right? And it kind of because it harmonizes our hormones, then it regulates our menses, right? And so when we do treat it, we kind of have to see the patient as a whole. What can I do to make her life better? What can I do to prevent things that she is prone to or at risk of just because she has a diagnosis of polycystic? So the main stream is to give OCPs. That is true, but there's other things that you can do as well.
Yeah. One thing that it did help with when I was put on birth control, it helped with my skin.
For sure.
I did not have a pimple throughout puberty.
For sure. Actually, that like a lot of the time, I would like to give OCPs, not just because to regulate her menses, but like you said, the OCPs makes a huge difference in terms of acne. And especially if you get acne when you're younger, then it gets kind of scarred, then it becomes even harder to get rid of, right? Also that they have a lot of hair loss, especially at the front. And so I want to give the OCPs to prevent scalp hair loss. And also kind of your skin glows, it looks really better, right? And then hair around other areas where you shouldn't have hair also decreases. So when you give OCPs, you're not just regulating the menses, but you're kind of thinking of all of that together. And that's kind of the best treatment for acne, for hair loss, to kind of prevent hair from other parts of your body. The other thing, the problem is though, like in our communities, it's kind of hard to accept taking OCPs when you're not married, and because that's the conception that we have, right? We take it if we want to prevent pregnancy. And also people kind of don't want to put themselves in the gray zone where like, people ask them, why are you taking OCPs, right? Because then that would in some ways might maybe kind of give them a negative outlook in terms of people, right? So a lot of people try to resist that, but especially if you're younger, then OCPs is something that you should really consider. The other thing is that when you have PCOS and then you have acne, you have hair loss, you have hair in parts where you shouldn't really have it as a woman, it actually affects you psychologically as well, right? And so PCOS in itself is associated with depression and anxiety, right? And so you add, and eating disorders such as like binge eating, for example. And so when you kind of add all of that and add acne and hair loss and hair in different places where you shouldn't really have hair as a woman, that's quite a lot for someone that's young. So that kind of helps to decrease some of that
And I think there's
psychological impact.
the added layer of the comments that you get from people as
for
well.
sure, for sure.
So there's, I think, a common misconception that if you have PCOS, you're going to not be able to get pregnant, or it's going to be a lot harder. You walk us through that a little bit, because I think with the added paranoia of like being on an OCP, like maybe people be like, if I go on an OCP, I'll never be able to get pregnant. Like I think there's a lot of like fear mongering on the internet.
So if you do have PCOS and you want to get pregnant, you can get pregnant quite easily if you stop the OCPs. It's not that you don't. It's just a little bit harder than people that don't have PCOS, right? So a lot of my patients would stop the OCPs, and then before we stop them, we kind of start folic acid, try to strengthen their body, get them ready to get pregnant. Introduce like good diet, exercise. And if there's changes in that lifestyle modification, that's what we call it, positively in terms of weight loss, in terms of exercising, and then she stops the OCP, she can actually easily get pregnant on her own. She doesn't always need help. But they are likely to maybe have certain medication that could help if they do want to get pregnant. But it's interesting, like if you lose 5 to 10, as a PCOS patient, if you lose 5 to 10% of your weight, that actually has a really positive impact on your hormones. So it doesn't always mean that you need medication in order to get pregnant. But if you do things like exercise and weight loss and stuff like that, then you can kind of sort it out on your own. It doesn't always mean that there's difficulty.
I want to kind of also get into endometriosis, because I know it's also very common, but it's also a lot of times I think, is it misdiagnosed, or it's gone undiagnosed, or people usually have a later diagnosis? Am I correct? Or
so actually, it's part of the dilemma in women's health, right? So as women, when we have pain, we are not diagnosed in a timely fashion relative to males when they have pain.
No,
right?
we're gaslit. We're gaslit being told, oh, this is normal.
Yeah. Oh, this is normal, or just deal with it, or there's nothing wrong with you, it's in your head, right? And so the diagnosis, because of that bias, kind of takes time until the diagnosis occurs, right? And that's our problem, not just in endometriosis, and even if we talk about cardiovascular disease. So I've talked about this previously, but for example, in women, when she has a heart attack, our symptoms are not classic, as in that you would have pain in your heart that radiates to your shoulder and then you kind of faint or something like that happens, right? That's not how that's not how heart attack manifests in women. She can have it as nausea. She can have it as a heartburn, right? She can have it as like kind of mid-back pain. So it's a different symptoms. And so when she does go to the Emerge, for example, they're like, oh, it's just a heartburn, but it's actually a heart attack, right?
And so I'm going to have a heart attack.
No, I was like,
we were just looking at each other panicking. I'm like,
no, please don't panic. A lot of people, when they do have heart attacks, there are certain risk factors for that, right? So it's not just, but what I'm trying
by the way, we're about to, every time we're going to have a heart attack. I already know.
But that's the thing, is that like we don't take time in terms of like a medical aspect or medical team. We don't always take time to really go through everything as we would if a male comes along. So in terms of endometriosis, it does take quite a bit of time to diagnose, because it's kind of normal in our communities that if you do have your period and you have intense pain, that's what usually happens during your period. But that's not what usually would happen, right? I mean, you would have pain that, it can go with Panadol, can go with like light medication. But if you're going to Emerge and you're getting medication, or it's like you're taking like stronger pain meds, or you're, not doing things that you love on a daily basis when you have your menses because of pain, or you can't go to work because of pain, then that kind of needs further workup.
And I believe the pain is sometimes chronic as well. Like it's not just when
It is. It's
your period.
Part of your differential diagnoses when someone comes in with chronic pelvic pain. So it's like they have pelvic pain or alam bil for a long period of time. Then one of your diagnoses, or one of the things that you think about, would be to rule out endometriosis. So yeah.
What about fibroids? Do they have anything to do with that? Because I think a lot of people usually, the same way endometriosis, wow, it's really difficult to say, gets misdiagnosed or ignored. I think it's the same with fibroids. And sometimes you can really see a bump on certain women. You're like, is that a fibroid that's grown a bit too much?
Yeah. So 70% of women actually have fibroids, and it's absolutely normal if you have it. It's not a big deal, right? But there are certain things where you would, as a physician, kind of look more into, right? So for example, if this fibroid is causing intense bleeding during your periods, and then that's something that we would need to treat. If it's something that's causing you a lot of pain, then that would be something that we treat, right? If it's causing compression symptoms, like you mentioned, it's quite big, right? And then it causes either problems with urination or problems passing stool, then, or like you can't breathe, or it's like huge, then yes, you would do something about it. Or if it's growing too much in a specific period of time, then you would act. But if it isn't fulfilling that criteria, there's absolutely nothing to do. It's normal to have a fibroid here and there. Usually our cutoff is like 5 centimeters and above, then that's when we would kind of have a closer observation of the issue. But if it's less than 5, even if it's a lot, we really don't do much about it. Right? Because there's nothing to do. Like, I don't like to over medicalize, right? If it's something that's not causing an issue, either medically or in terms of your quality of life, then don't touch it. Right? But then if it is, then we'll do something about it. Same thing with endometriosis. Sorry to go back to it. But for example, with endometriosis, what you want to do is to, two things really, either to control the symptoms in terms of pain and how debilitating it can be, right? Because people would look at some of the endometriosis and say, well, I mean, she looks good when she doesn't have her period. There's nothing wrong with her. And then when she does have her period, she's like, in bed, in pain. And they would probably say, well, like, take some pain meds, go to Emerge, it'll be fine. And then after her period ends, she's fine, right? And so it's in terms of endometriosis, there's two things that we want to do: either medically treat it in terms of either stopping the menses so that there's no bleeding and therefore there is no pain. Because the problem with endometriosis is هي بطانة الرحم, or how we call the endometrium, which is the inner lining of the uterus. Basically, in endometriosis, the lining of the uterus is not only within the uterus, it goes to other places. So it can kind of cover the ovary or can cover the bowel. There are certain people actually had it in their lungs, right? I know, right? So when she has her period, that lining bleeds no matter where it is, right? And so if it's inside your bowel and it bleeds, then the tissue around it would be inflamed, and that causes the pain. Now, when it becomes inflamed, then the body tries to react and calm that area down. And part of that reaction forms adhesions. So يصير عندها التصاقات. So now she has بطانة رحم مهاجرة, or endometriosis, plus التصاقات. So sometimes during that period, we actually want to stop the period 100%, because if we do, that means the areas, like the lining that is in the abnormal area, then stops bleeding. If it stops bleeding, then there is no inflammation. Then there's no inflammation, there's no adhesions and pain, right? Yeah. So that's how we want to treat it. So that's number one. The other thing is that a lot of people think, well, I have endometriosis, I want to have surgery, I want to remove everything that can bleed. The problem with having surgery for endometriosis is that you are prone to having adhesions, or you're at risk of having هذه التصاقات. So you'll basically be having endometriosis and adhesions, right? Okay. Which makes the pain worse with time. You might feel great in the first 6 months or up to a year, but then after you might have pain. So we do surgery, especially if someone wants to get pregnant and we want to kind of clear the area and have her ready, for example, if she wants to use IVF or whatever, then that's something that we can do. But there's certain criteria to do surgery. And the recommendations from all medical societies is to push that surgery as far away as you can, because you don't have to go and do multiple surgeries for endometriosis, and that would cause adhesions, and she'll get into a cycle that'll be very difficult to get out of. So we do surgeries, but there are certain criteria, because you have to make sure that خير العملية أكثر من شرها, right? So you want to do right by her, right? So yeah.
So then walk us through how, like for someone that's like listening, that is going through that needs to understand what the options are and what the consequences are. How do you stop the menses, and like what are those consequences on like a normal person?
Yeah, so there's a couple of ways to stop the menses. So for example, when we talked about OCPs, or oral contraceptive agents, so there's two ways to take them. So in PCOS, for example, we take it cyclic, which means that she'll take the medication that harmonizes her hormones, and then she'll stop in a specific amount of days, like usually 4 or 5, and that's the area or the time where she would bleed, right? With endometriosis, when we want to stop it, we take it continuously, which means she takes it every single day in order to completely stop bleeding and not have a couple of days where she would bleed. So that's and I usually like OCPs in terms of treating endometriosis, because you don't have a lot of the side effects of the more kind of stronger medication. So those stronger medication would include completely stopping the estrogen, or what we call medically induced menopause. right? So we completely cut off the estrogen. And if we completely cut off the estrogen, then therefore there's no estrogen, there is no period. And so the problem is you can either take it as a medication or you take it as an injection that stops the period for a specific amount of time. But the problem with medically induced menopause is that then you have all the symptoms of menopause, right?
Yeah.
You have the hot flashes, the night sweats, the mood instability, you have anger, you might have depressive symptoms, right? You might have brain fog, you might feel weaker. And so and then if it continues for a long period of time, because we usually would like that for a couple of years, right? So if that also continues, then she would be at risk of having, for example, osteoporosis or hishashat idam, right? She would be at risk of having cardiac issues. Why? Because estrogen is protective. If I stop that for a long period of time, then it will affect my heart. رح يسوي لي هشاشة عظام. And so we go into other aspects, right? So I usually would prefer the OCPs unless I can't control the OCPs. I would need to go to something further.
Yeah.
So that's always the first line, is to treat it without surgery. But if it's not responding to medical treatment, if it's intense pain, if she wants to get pregnant pretty soon, then we would consider surgery.
So I know that the main symptom with endometriosis is very painful periods, right?
Yes.
So because I know a lot of, or most women have painful periods, but that doesn't necessarily mean that it is endometriosis, correct?
Yes.
So what are the telltale signs for women to get tested? Because we also know that there is a cultural stigma when it comes to unmarried women. There is the fear of seeing an OBGYN.
Yeah.
So what are the telltale signs, or when do we know that we need to get tested for endometriosis?
So you kind of touched on a topic that I'm very passionate about in terms of whether you're married or unmarried, you need to see your gynecologist, right? Because there's a lot of things that we can do as prevention, not just as treatment. And so you need to see someone that specializes in women's health so that you can continue to be healthy and strong, because you don't want to go to your doctor when things are bad. You want to kind of go a bit earlier so that we prevent things that are bad, right? And we also educate you on a lot of things that can be helpful for your health, right? So that's really important, and that stigma kind of needs to go away.
Yeah.
So that's one thing. So in terms of endometriosis, so when you have a lot of pain during your period, it does not automatically mean endometriosis. There's a lot of other things that can occur. But sometimes if that pain is not controlled with Panadol or Profen or like simpler pain meds, and you kind of have to go to Emerge to get like IV medication, right?
Yeah.
Or if you can't work because of the intense pain, then we would consider that you might have endometriosis. Usually people that also have endometriosis have like cysts on their ovaries that contain that menstrual blood. And it's quite distinct when you do the ultrasound. We can diagnose it with that or with an MRI, right? And so there's a lot of different ways to kind of figure out if you have endometriosis. So it's a clinical diagnosis and imaging diagnoses. You can't really, right now, we don't have markers in terms of blood tests that can tell me if someone has endometriosis or not, but it's in the process in terms of research, but not something that we can use significantly clinically.
Yeah. So I know I've at least from, a social level, talking to our friends, we've heard a lot of our friends say that post-COVID vaccines, that they've noticed a significant change in their periods and their cramps as well. From a medical perspective, have you also noticed something along those lines?
So we like to follow what we call evidence-based medicine, right? So you do a research, you come to a conclusion, and then you apply it clinically, right? So that you know that it's truly safe for your patient. We haven't had research that would corroborate that, right? We don't have evidence, and it doesn't make sense from a scientific perspective that because either you got COVID or you got the COVID vaccine, that would affect your menses in the long term, right? So I don't have evidence for that. But there's a lot of things that people need to take into consideration in terms of, well, first of all, you're older, right?
Yeah.
And just being older could affect your menses, number one. Number two, is your lifestyle the same, right? Because are you eating the same? You're exercising the same? Is the stress in your life the same? So there's a lot of other reasons that can cause these changes. It's not always related to COVID. But I think what's happening is that after COVID, we're more health aware, right? We are like our knowledge, or the community's knowledge of like medicine and what to look for is a little bit better because they had to research things because we didn't know what was happening, right? And so people started reading instead of just depending on what a physician would say. Right. And also there's a lot of like social media in terms of Instagram and stuff like that would kind of bias people in terms of thinking, oh, maybe this is what's happening, but it's not always medically correct.
Okay.
That's our problem. Yeah.
We just love talking about it all the time.
Yeah.
Our girlfriends are
Every
like,
day.
I noticed that my cramps changed after the vaccine.
Yeah.
It's that vaccine is the culprit for everything.
But I will say though, like overall,
Yeah.
it's a conversation I've had with almost every girl.
Almost every
Yeah.
girl.
I mean, a lot of people relate a lot of what it's happening to them because of either they had COVID or they got the COVID vaccine. Because it's like, it's something that's recent, something that we don't have enough data on what's happening, which is like, for example, opposite to the HPV vaccine that we use for cervical cancer. That vaccine has been studied intensely like for 20, 30 years, right? So we have a lot of data. If you come with a certain thing after getting the HPV vaccine, I can tell you using evidence-based medicine that this is not related to the vaccine, or this might be related to the vaccine, right? Other than COVID. COVID has just been a few years. It's a different technique. So I think we still do relate it, but we don't have the evidence to kind of say, yes, it's because of that. Yeah.
So I kind of want to go back to the challenges that unmarried women face.
Yeah.
I think it's very important to shed light on it because I think it would be nice if we had more awareness on that topic. So how do we empower women and push them into, seeking medical help or seeing a doctor and getting checked, even if they're unmarried?
Yeah. So I think that people need to do research on the physician that they're going to, right? So you want to look for a physician that has qualifications in gynae. But the second thing is you need to find a physician that is similar to you and to your views of life in a way, right? Because you're going to be with this physician for a long time, right? And so you have to be comfortable in saying things that you probably would not say to other people, right? And so I always tell my patients, if you go to someone, including myself, and you don't feel comfortable, dump us and go to someone else, right? And shop until you find someone that meshes well with what you want. So research that physician, find out if you feel comfortable with that physician, and then go to seek them. But don't kind of say, I don't like him, but he's the doctor that's there. You have a right to change your doctor, whether that is in the government hospital or in the private. You have a lot of power as a patient, right? And so take that power on, right? If you don't like something, just say it, right? Even if, for example, even if you go to a physician and there's certain treatments that they would recommend, ask, like come in with research if you like, right? And ask us, kind of challenge what our recommendations are, because then you would understand why. And if you understand why, then you're more likely to do what we're asking you to do to help you. Does that make sense?
Yeah.
So that's number one. Number two, I have actually a lot of patients that would come and just say, there's nothing wrong with me, but I just want to make sure that I'm kind of heading in the right direction in terms of health, because I do a lot of women's health, specifically above the age of 40. And I also see a lot of adolescents, right? So like in the teen years as well. And so it's good that they come in, because then we can teach them a lot of things that would prevent diseases. So for example, if someone with PCOS comes in early and we introduce lifestyle modifications early, I might not need to use medication later on. Does that make sense? It's not always the case, of course, but there are things that I can do before it becomes severe, where I need to go for surgery or I need to give medical treatment. And I think no matter what physician that you go to, you kind of need to make sure that they see you as a whole, right?
Yeah.
So you want to give your patient medication. You want to do surgery, for example, for this specific diagnosis of PCOS or endometriosis or fibroids. But you need to make sure that that's truly what's best for them, right? It's not like you read their recommendation. So for example, as physicians, once the problem in medicine is not the treatment, because there's protocols for that. The problem in medicine is having someone that gives you the right diagnoses, right? Because then treatment would be easy, because there are certain recommendations for every single diagnosis. And this is what we learn throughout medicine, right? But you have to go to someone that gives you the right diagnosis, right? But once you have that, I always you need to see the patient as a whole. So yes, I would give, for example, OCPs for someone that has PCOS, but I need to think about their acne. I need to think about their hair loss. I need to think about how am I going to motivate her to go exercise, right? Does she know how to exercise? When we talk about the diet, I can't just say these big vague terms of get protein. That's not it. What protein?
Or I had a doctor tell me get
protein.
Gastric bypass.
Right?
She actually told me, she was like, you need gastric bypass.
It's I hate those so you can't just give shi'arat. Yeah. You have to really see this person and see what diet, exercise, medication would actually work. Right? So for example, if someone takes oral contraceptive agents for OCPs, one of the things that we always tell them is that you have to take the medication at the same time every day. So what's your lifestyle like? When do you think is a good time that you will take it, that you can stick by it? Because if she takes that OCPs in different times, it will dysregulate it, right? Because our aim is to harmonize. So you need to make sure that they are aware that they take the medication at the same time, or at least within half an hour every day. Yeah. So you, as physicians, you have to kind of take a step back and think of our patient and how اللي أنا قلتها will impact her.
Yeah.
Right?
Ideally, how old should a girl be the first time she sees an OBGYN? Ideally.
So usually لما تبلغ, she can go to see a gynecologist, because أول ما تبلغ, sometimes some people البلوغ عندهم is very smooth, right? They have their periods and they're fine. But we actually have a good portion of young women who have their period والperiod عندهم متلخبطة, right? So their mom or their grandma تقول هذه عادي because هذه أول سنين, and then that's fine. صح كلامهم, هو عادي, but there are certain cutoff points. So if she's getting her period every 19 days or less, then that's a problem. If she gets her period every 3 months and above, then that's a problem. صح? But how do we know that? When you see her gynecologist. If you see her, she's fine, she's getting it مثلا every 2 months, every 6 weeks, that's okay. Because she's young and her body's learning to harmonize itself. It does not immediately mean medication. But for example, if she is obese, then that's the time when we can help her to lose weight, right? If she's not exercising, that's a good time to teach her how to exercise. For example, as we said, لما تتلخبط عندنا الدورة, early, if you're starting to have your period, you're afraid, is it a good thing or a bad thing? What's happening? Anxiety, depression increases a little bit, right? So if you have a doctor that reassures you that this is okay, and then kind of looks for signs that she might be at risk of anxiety or depression, we can alert the parents early, right? Look for that. If that happens, and then we need to kind of teach her lifestyle stuff in terms of how do you deal with stress, right? How do you deal with depressive symptoms? So we can start things early. So I usually like it to be a bit early. If they're super healthy, we can see them every 1 to 3 years, depending on what's happening. If they're unmarried. If they're married, of course, we see them on an annual basis. Yeah.
So what are the most common misconceptions when it comes to the symptoms of PCOS? I want to, focus on a little more, because a lot of times people don't understand that someone with PCOS might have a tougher time losing weight. And they probably put on weight at a more rapid rate than someone who doesn't have PCOS.
That's true. Yeah.
But what are other common misconceptions that you've seen?
So in terms of it is harder for them to, or for patients with PCOS to lose weight. It's also harder for people who have endometriosis to lose weight, because what's happening is that there's inflammation within their body, right? And inflammation makes it harder for you to lose weight, because your body is in stress because of the inflammation, because of the pain. So in terms of PCOS, there's a couple of things that you have to do. So you have to control the insulin resistance, right? In terms of, because if you control insulin resistance, you can lose weight. And also they'll usually be depleted in a lot of vitamins and minerals. So you also need to kind of cover for that. Because if they're trying to lose weight, they're on a diet or they're exercising and their body is not there yet, and they're forcing themselves to be on a diet, their body kind of goes into a starvation mode. They think it's like, oh my God, we don't have food. We need to kind of keep that fat that's in the body. But if you supplement with proteins, protein shakes, you supplement with vitamins, things that are essential for the body would kind of calm down. So the first period of trying to lose weight in someone that has polycystic ovarian syndrome is to soothe the body. So I'm actually going to ask them to eat way more than they want, and take the vitamins and take the proteins, take the minerals, so that their body kind of gets out of that starvation mode. Because I can't do much if it feels that it's going to hold on to that fat like so hard that I can't break it. Does that make sense?
Yeah.
So the first period or the first 6 weeks is just soothing your body. And then after that, we introduce the diet. Does that make sense?
Yeah.
So some people, for example, intermittent fasting can be helpful. Taking some of that medication, like that's all over the community right now, like Ozempic and Mounjaro, can be helpful because it targets two things. It helps you to lose weight and it harmonizes your insulin resistance. So it does two things at the same time. Even when you mention surgery, I'm not against that because I have to weigh the risks of being obese, right? And all the things that follow versus just kind of having the surgery in itself, right? So there's a kind of like a balance between the two.
Yeah. So I know recently with the rise of Ozempic, we've seen, I think, studies that suggest that it has helped with fertility with women with PCOS. But is that the first thing that you would recommend someone with PCOS? Isn't it better to sort of help someone understand better lifestyle habits than, kind of give them
for sure. So
fix?
as I said before, like the first step is always lifestyle modification, which means exercise, as we mentioned, diet, stuff like that. So we should, like, after a diet that soothes you, and then we try to have what we call a high protein diet. And exercise. If it doesn't help us to lose a lot of weight, then we need to go to other medication because we do not want you to have obesity for a long period of time because obesity puts us at risk of a lot of things. So for example, because of PCOS, you might have some insulin resistance, right? But you don't have frank diabetes, right? But if I have insulin resistance and your weight is increasing and you're highly likely to actually have frank diabetes, then I need to get that weight down as soon as possible. Right? Also, when you have PCOS, then you have your estrogen is not balanced, right? So it could be higher than usual. If it's higher than usual and you're obese, because estrogen, it's basically secreted from the ovaries and it also comes out of adipose tissue. So people that have a lot of fat on their body, basically they actually have estrogen from their adipose tissue or their fat. That's what we call it, right? And so now the estrogen is like a bit higher than usual, which puts it also at risk of certain things like, for example, cancer. Not when you're young, but when you're older, and this has continued for years ahead, right? So it's really important to get that weight down. That is a focus that we need to have for patients that have PCOS. And so because of that, that's sometimes where I would consider these medications such as Ozempic and Mounjaro, because the risks of having obesity and PCOS and insulin resistance is a lot. Right? So at least I need to kind of decrease some of that risk. I'm not saying that you should go and get that medication. I'm saying that you should go get that medication after we have seriously tried to lose weight and have failed.
Yeah.
Does that make sense?
Yeah.
But it's not like sometimes in Kuwait or in other countries, you can easily buy the Ozempic and Mounjaro without even a prescription, which I believe is wrong. But you shouldn't just because if you have PCOS and trying to lose weight, just grab it. There's a lot of things that you can do before, and that's what you should do.
Yeah.
Especially because I think the consequences of these medicine on people who don't have diabetes, like, we still don't really know. I mean, it's still really new. And I think what I've seen on the internet, which we've discussed before, it's you see people on Mounjaro and on Ozempic losing weight, and then I think they said 1 or 2 years afterwards they'll have taken back like 2/3 of the weight, put on back 2/3 of the weight that they lost.
So it's true. It's not. So actually, the theory behind Mounjaro and Ozempic is not new. It's just new to the community, but it's not new to the medical field. Does that make sense? The other thing is that people take the Mounjaro and Ozempic without really seeing a physician or seeing a nutritionist to kind of help them through that weight loss. So if someone takes the Mounjaro, takes the Ozempic, and actually exercises and builds muscle, then they would not regain that weight as much, right? But if you take it unsupervised and you lose the weight, you're basically losing muscle mass, not a lot of actual fat. You do, but not as much. But if you have someone that's supervising that process, then the risk of you kind of regaining all that weight back is way, way less. right? But it's if you just take it كذي ما ماكو أحد قاعد يساعدك during that process, then there's of course you're going to regain it all back.
Yeah. If a girl has PCOS, and obviously, like, we know you're not going to want to make a blanket statement, but during Ramadan, obviously we know that food and hormones is very linked. So for a girl with PCOS, food could be medicine. What can she do to fast and exercise during the holy month in a way that helps her, like heals her, or at least doesn't harm her?
So actually, Ramadan is like a really good time to harmonize your period, right? Because in a way, you're doing intermittent fasting. صح? طبعا intermittent fasting, just to be clear, does not work on all PCOS patients. It doesn't mean that this is what you do to treat it. صح? So everybody is a bit different because PCOS in itself, different types as well. But if you fast, the majority of patients that have polycystic, it actually is a good thing because it decreases insulin resistance and عندك ساعات where you're not eating, right? So, but when it comes to فطور, because we've been starving basically for all those hours, الناس يعني يدبونها أكل, right? تاكلين الأخضر واليابس, you know? And so it's like sambusa على شوربة على, you know, like,
and then you just feel so full. You can't
feel dessert. Let's go for dessert now.
Yeah. So I usually like to say يعني مثلا تاكلين مثلا for example تمر and your لبن, and then just cut it a little bit, and maybe روحي صلي, take a break, and then go back to really eating. So a lot of my patients يعني مثلا إحنا نحب التمر واللبن together. So I ask them to ياخذون اللبن that has that extra added protein. تلقينه بالجمعيات, like you find it in the هذا. So there في لبن يكون في مثلا تلقيه مكتوب 20 grams extra protein, 30 grams extra protein. So that's really good because here she has protein intake. Plus هو يقث لما تاخذين protein shakes or لبن مع protein. هو اللبن أصلا يقث. Plus you take the one that has يعني more protein. So if she تاخذ التمر and then she takes the لبن that has the protein and then she takes a break مثلا تصلي or helps with whatever, then that's a break where her brain will think, oh, okay, I'm good, I'm full. So when she comes to actually eat the فطور, it's like she will eat less أصلا, right? Because it's very hard to restrict somebody برمضان. Right? Because انت رايحة عزايم and someone did this specifically for you. So it's hard to keep saying no to people. But, and وانت جوعانة, so you're going to eat a lot of things. And so if you kind of do that breaks it a little bit, so you have a bit more control about what you're eating during the actual فطور. I always say, like, whatever you eat in terms of protein, in terms of فطور, try to prioritize eating protein. So for example, if you have مجبوس, then eat the chicken first and then اكلي العيش or هذا. Because it's hard to say لا تاكلين العيش. بس إذا خليتي تمر ولبن وكليتي الchicken and then maybe a little bit of شوربة, by the time you come to eat the rice راح يكون شوية أقل.
I mean, I know also our sleep cycle gets impacted as well during Ramadan. And I know sleep is also very important for women with PCOS to have like regular sleep cycle. So how do you also kind of limit the damage that has on you? Like also we eat later at night. So how do we sort of manage all of this and
so to be honest, يعني I always like to give my patients advice that's practical, that's real, and that they'll actually do. لأن ما أحب أعطي شعارات. يعني نامي الساعة 10, it's just not gonna happen. يعني خاصة برمضان.
Who are we kidding?
إن شاء الله دكتورة, I shall never do it. صح? So أنا يعني حتى مثلا like for example, يعني so if it's يعني as long as يعني during Ramadan, it's a period of, in a way, of happiness and social gatherings, right? And love. والناس قاعد يتجمعون على طاولة. And that actually يعني has a lot of a positive impact on your health. I'm not saying يغنيك عن sleeping well, but I'm just saying that there's a lot of positivity that can come out of it. So إذا معناته أنت راح تسرين الوحدة because أنت سهرانة مع عدتك ولا ربعك ولا هذا, then that's fine. That's okay. If you're having consistent problems with sleeping during Ramadan, then we can intervene. But لو أنت بتنامين الصبح تنامين بالليل, it's okay. Enjoy it to the max because it brings you happiness, and happiness is something that will positively impact your health. If you're having problems sleeping, يعني مثلا أنت سهرتي and صار الصبح and بعد ما تنامين, and then you're becoming تعبانة and tired because of lack of sleep, then we can intervene. And that usually, for example, you can either exercise to the point of being really tired and then for you will sleep, or you can add like stuff that are not addictive, that will not affect you. نفس مثلا magnesium glycinate that we've talked about before. So مثلا magnesium glycinate taken a dose of 700 milligrams 2 hours before you sleep can help you to sleep. I'm not saying in terms of increasing the hours of sleep. I'm talking about the quality and depth of sleep. So that can help you, for example. But I don't want people to restrict themselves and not enjoy things and not enjoy love and happiness and gathering and social aspects because they're worried about all of that.
Yeah.
Does that make sense?
How can they exercise effectively though? I mean, do you say, okay, cut down the exercising? Do you say try and augment it? Do you recommend people exercise at a fasted state? Because Zainab and I, we kind of like exercising on empty stomachs. It kind of works for us. Like, is there anything in particular you'd recommend?
So I guess the short answer would be no, as long as you exercise. Exercise متى ما تبين, as long as you exercise. صح?
Okay.
There's been a lot of research about like, should I do the exercise while I'm fasting? Or should I do the exercise بعد ما كليت الفطور? Everybody is different. Sometimes it's effective حق بعض الناس قبل الفطور because they've already kind of not been eating and so the cycle is better. Or some people ما راح تقدر تسوي all that she can and exercise عدل قبل ما تاكل. So then you can do it after. I don't mind when. All I mind is that you actually do it during Ramadan. When you're doing it during Ramadan, what I want is always strength training. Do cardio, and cardio is good. It's good for your heart health, but it doesn't build a healthy body as much as including strength training. صح? So strength training is building muscle mass. So a lot of patients that come to my clinic, for example, I ask them for تعرفين هذا like the fat percentages, the muscle percentages, because you can no longer just depend on a BMI. Someone can have a perfect BMI, but they're like super unhealthy, right? Because it's all fat, be it fat من برا or visceral fat, which is internal fat, right? And so it doesn't matter what your BMI is. It doesn't matter the number of what your weight is. It is not always a reflection of your health, right? So you need more details. So at Ramadan, when we actually put a regimen that they'll follow, I ask for that muscle mass and fat percentages before, and then 6 weeks or 3 months after, depending on the program, I ask for it again. Because all I care about is that muscle percentage or muscle mass increases, especially for women. Yeah.
Well, you're going to catch us at the gym before.
You will be seeing us struggling.
I love working out on an empty stomach. I cannot work out after food. I have to do it.
That's fine. It works.
Zainab is a witness. If I work out after food, I will be throwing up.
Both of us. And that's why we're friends. And we do strength training as well. So that's something that I've learned over the years of having PCOS for, I think, I would say I'm 24 years. 14 years now. It's 24 years. Is that like I try to avoid HIIT training. Like I do HIIT training every once in a while, but I focus mainly on strength training and slow paced cardio. Yeah.
That works. As long and HIIT is not bad, but there's other things that can benefit you a bit more. So if you like it, you can do it. إحنا ضده, بس there are other things that can really make a difference in terms of your health, for sure. So for us women, when we do talk about strength training, I'm not talking about like building muscles in your arm or building muscles or having a six-pack. In terms of our health, what really matters is that you build the muscles of your glutes, your thighs, and your calves. That's really what has a huge impact out of your health. Other things are good. I mean, you look great if you do, you have a six-pack, you're doing core muscles or you're doing arms. But in terms of like health benefits, we always like to focus on like from the pelvis and downwards.
We don't skip leg day.
We're never going to have a six-pack. I was going to say, we don't skip the leg day, but we're never getting a six-pack.
Mentally, I want to be able to get a six-pack. Realistically, I like carbs. I'm not skipping.
So it's actually, I think it's just like one of the things where like socially it's pushed upon us that you should have a six-pack because that's when you look amazing, that's when you look great. But it's not always a reflection of how healthy you are. So I mean, it's great to have a six-pack, but again, it doesn't always mean that you're healthy and you're amazing, because sometimes people exercise to the point where it actually becomes bad for you. صح؟
Oh, wow. Couldn't be me.
So there needs to be a balance. Not a lot of exercise and not a lot of مثلا dieting and high protein. There has to be like a balance أساس إن توصل to the weight that you want, because some women, if they over exercise, then they actually have problems with their period. صح? Because then you have an imbalance of female hormones because of over exercising. And then your BMI يكون low, your fat percentages become low, and therefore it'll affect your menses. So it has to be a balance between the two يعني. Like a lot of women حتى when you look at the table that they give you for like fat percentages of your patient and then with the normal values. So in normal values, it's actually quite a big range. But there's a certain range where it's considered normal, but it actually affects your menses. فاهمة قصدي؟ يعني أنت تيني تقولي والله ترى ندى look it's طبيعي. I'm like لا it's طبيعي for health generally, but for your female hormones to be harmonized, this is too low. So we need to build it up again.
And what is that number that you think
we
is
like
too low?
Yeah, so we like the cutoff to be like in terms of BMI, we like it to be 22 and above. Right?
Okay.
Yeah.
Wow.
Yeah. Fat percentage for women is higher than men.
صح,
because it protects us, right?
It does. It is actually good for you because, as I said, the estrogen قاعد يطلع من your ovaries, but also يطلع from your fat, right? So we do need that. And that's why لو تلاحظين, men have heart attacks earlier than women. They have more severe heart attacks than we do, right? We live longer than men. It's because of the estrogen, right? That's what's protecting us. So we do need a little bit of shahm, like being super lean is great for you, great for, your body. You look amazing, but it doesn't always reflect health.
Yeah.
Does that make sense? Yeah.
Well, that's good news. Ending on a high.
Let's celebrate our fat.
Exactly. And I love your approach where it's more balanced and sustainable.
Yeah.
And I think that's realistic.
Yeah.
And I think that's very important for women to understand that you don't have to badger yourself with all this guilt to meet an unrealistic standard, I guess.
Especially when all the like health and fitness gurus have like these like really lean bodies with six packs. So it's like, oh, actually, I don't have to be that way to be healthy.
No, you don't. Like, يعني, and I like it's something that always bothers me. لأن يعني, there's always like they always build this image of how you're supposed to look like, but it's not always healthy. Yeah. But people don't know, and therefore they're like, oh, this is like the icon of being healthy is to have that six pack or that lean or the biceps, so kill part of your muscle shows, right? It's not for us as women, يعني.
Yeah.
I mean, it's great, but that doesn't always mean health.
Well, definitely ending on a high note. Thank you so much.
You're welcome. You're welcome.
No,
such a pleasure. Indeed. Honestly, this was a very insightful conversation.
Thank you.
I think we can officially call ourselves Women in STEM.
We are Women in STEM, recommended by Women in STEM.
All right, you guys, if you enjoyed this episode,
don't forget to like, comment, subscribe, anything below 5 stars and you're a hater.
All right, you guys, we will see you next Wednesday. Bye.
Bye.